In the urea cycle, there are 5 main steps, in which 2 steps are performed in mitochondria and 3 steps are performed in cytosol. How can you differentiate it? It is necessary. Question is asking right about urea cycle. So what the examiner asks? Examiner asks, you have to draw the flow chart of this reaction. What you draw? Flow chart of this reaction. That is important. Okay. After then, some other things are there. So first thing, in the first step, that is urea cycle, the first step is CO2 combined with ammonia. Because what is urea cycle? Urea cycle is the disposal of ammonia. Disposal of ammonia. So these first condense with each other. How this CO2 is come? From which cycle? Because we already discussed this class. So I just repeat this class. Very good. TCA cycle, then by first enzyme CPS first, there is a formation of carbonyl phosphate. Carbonyl phosphate. This is the first mitochondrial step. This is first mitochondrial step. How this enzyme is regulated? With the help of enzymes. Regulatory, this is called NAG, N-acetyl glutamate. It is allosterically regulate this cycle. Means allosteric regulation means this can regulate the enzyme activity. This can activate the enzyme activity. Now after then, ornithine combined with this carbonyl phosphate, and there is a formation of another compound called citrulline. Citrulline by enzyme OTC, ornithine transcarbamylase. Ornithine transcarbamylase. So students, these both the steps. This is first enzyme and this is second enzyme. These both the steps are performed in the mitochondria. In the mitochondria. Okay. Now, in another step, there is a formation of arginosuccinate. May I write? Arginosuccinate. Which enzyme can participate in this reaction? Arginosuccinate synthetase. So there is requirement of ATP. In the first step, there is 2 ATP. Is converted into 2 AMP, adenosine monophosphate. Okay. So same here in this step, they also take 2 ATP, forming 2 ADP with inorganic phosphates. So arginosuccinate now going to further breakdown of this succinate and forming argine with enzyme arginolase. Okay. So in this step, there is a removal of another substrate which is directly participate in the TCA cycle? Can anyone tell? Fumarate. There is removal of fumarate, and this fumarate is converted into malate, and these malate converted into oxaloacetate, and now this can participate in the TCA cycle. So these are what? These all are interlinked between TCA cycle and urea cycle. Okay? Argine. Now in the last step, this argine is now further on converted into ornithine by enzyme. Very good. Arginase, and there is removal of ammonia. Sorry, urea. What I write? It is urea, that is NH. What is the molecular formula of urea? NH2. So all the processes are there. After then, these urea become going to further on in urine. Okay. In urine and removal of urea. So what is the clinical application? What is the importance of this cycle? From the urea cycle, we remove the excess amount of urea from the body into the kidney. First thing. Okay, it is happening in the liver. The patient who are suffer from acute liver disease, chronic liver disease, liver cirrhosis. So there is accumulation of ammonia, which causes ammonia intoxication. If there is high elevated level of ammonia occur in the body, they causes directly impact on the brain. So why this ammonia is toxic for the brain? Question is asking like that. Who can give the answer? Just raise your hands. Why ammonia is toxic for brain? Tell me the student. कोई एक बताएगा, please raise your hand. I already discussed this in the previous class. Just I revised today. Okay. Why ammonia? This is prominent question. Why toxic for brain? हमेशा से ये क्वेश्चन एग्जाम में आता है. Not in the first class, it is all comes in your all exams. Okay, why ammonia is toxic for brain? You can give the answer. If I will, you will give the answer. How ammonia is present, in which form? Glutamine or glutamate? Glutamine. Amine is what stand for? Ammonia. Just simply understand. Okay. Glutamine. And how this glutamine is formed? By glutamate. Do you know the reaction of oxidative deamination? There is removal of ammonia from glutamate, from glutamine. Okay. And this glutamate is formed by transamination reaction, by which method? This is transfer of ammonia by oxaloacetate. If there is intoxication of this glutamine, there is means if there is high level of ammonia in the brain, high level of ammonia in the blood, that means glutamine is present in more amount, then feedback regulation, these oxaloacetate can impact this not form, and this is the main intermediate step of TCA cycle. And due to this, if this is not formed, the ATP production is stop. If ATP production is stopped, subject become depressed, non-active. Okay, and due to this, person feel very depressive. And lastly, this is the first step. That means if there is high level of ammonia in the blood, it can lead to less production of ATP due to impaired function of TCA cycle. Okay. Now second one, there is less formation of GABA. This is gamma aminobutyric acid. Gamma aminobutyric acid. It is neurotransmitter. If it is less, then there is inhibitory regulation of neurosignaling, okay, neuron cells, and this also leads for the formation of serotonin. Serotonin, no, it is well-being hormone. If the serotonin level is good, person feel good, and if the serotonin level is less, they are suffer from insomnia, lack of sleep, and other things. Okay, so all are the reason that this ammonia is toxic for brain. Now, if we discuss the disorder of this urea cycle, that first disorder is hyperammonia. First, hyperammonia. Second, third one, citrullimia. इसमें देखते जाओ, लिखते जाओ. It is very easy to understand. You will write with the substrate. There is 5 enzymes. If 5 enzymes is deficient, then substrate become accumulate. Such like that, if OTC is not work, which one is accumulate? Ornithine. If arginosubstrate synthesis is not there, which one is accumulate? Citrulline. Okay. Fourth one, which one? Arginemia. Fifth one, orthonemia. HHH syndrome. एक आपके लिए है, कौन सी है वो देख लेना आप, ठीक है. So these all disorder leads to a one condition which called hyperammonemia. ठीक है. देखिए थोड़ा सा देख लेते हैं, फिर उसके बाद समझते हैं. यूरिया साइकिल क्लियर हुआ सभी को? स्टूडेंट लास्ट बेंच समझ में आया? यूरिया साइकिल, व्हाट आर द साइट ऑफ यूरिया साइकिल? Which is the site of urea cycle? Second to last bench, students, all girls, please tell the answer. Where this urea cycle happens? कहाँ पे हो रही है urea cycle? Answer दो. Last time we already discussed that metabolism have two parts, catabolism and anabolism. In the catabolism process, there is productions of ammonia, okay, by two main reactions. Which one? TCA cycle and others, okay. अभी क्लियर हुआ? Why I tell you interconnection? That is CO2 is required for the first steps for the formation of CPS. This comes from TCA cycle. Okay, and this ammonia is directly go to the urea cycle for disposal, and there is production of urea. Okay, and these ammonia is not all the ammonia of the body is not toxic. If it is in high level, it will become toxic. Okay, and rest of ammonia goes to the formation of biosynthesis of bioamines, nucleotides, and biological amines. So all these are the formation and sources of these components. Okay. Removal, you already know there are two reactions, transamination reaction and oxidative deamination reaction. Last time we discussed in detail all of these reactions. Okay, there is a PLP dependent enzymes reaction. PLP stands for vitamin B6, that is pyridoxal phosphate, which can lead to transfer of amines group from one ketoglutarate to another glutamate. And these are the enzymes which we call transaminases. There are two transaminases mainly, SGOT and SGPT, which we stands for serum glutamate oxalate transamination and serum glutamate pyruvate transamination. Okay, or other name is alanine transamination and aspartate transamination. Okay, so in the muscles there is a storage form of ammonia is alanine. Okay, and this alanine is further proceed by this reaction, alanine transamination. Okay, and it is called glucogenic amino acid. Now you listen, L-alanine by enzyme ALT and PLP, there is a formation of pyruvate and L-glutamate. Okay, and pyruvate is a substrate for which reaction? Gluconeogenesis. Gluconeogenesis. Okay, so that's why it is called glucogenic amino acid. Those amino acids which can directly participate in the formation of glucose. It is called glucogenic amino acid. Generally in your viva, the examiner asks the question, which one is ketogenic amino acid? Because it is simple answer. Understand? Faculty and examiner ask from a simple one, then going to the harder one. Simple से शुरू करेंगे. एक क्वेश्चन पूछ लिया, give the answer of ketogenic amino acid. If you are able to give the answer, then it's going to the next step, then it's going to the other step, then it's going to the metabolism. Okay, so it is important to all of you to read these smaller questions clearly. You will know the answer clearly. Which one is glucogenic amino acid? Which one is ketogenic amino acid? So all these things are very important. Okay. Clinical significance of this transamination reaction, because we discussed all this clinical significance already in clinical enzymology. That is role of SGOT, role of SGPT in different disease and disorders. Okay. It is mainly for liver and heart damage. It is SGOT. Students, in your spotter section, I will give you the graph of myocardial infarction. Myocardial infarction. The graph is like that. There is a different level of enzymes like SGOT, LDH. Don't talk. So all these graphs are become higher to less, okay, with reference of time. And we remove the name of these enzymes and ask the question, identify the enzyme. So basically in myocardial infarction, there is only a one important enzyme, that is SGOT is raised. From the SGOT level, you can diagnose a disease called myocardial infarction. Okay. Now deamination, removal of ammonia. Listen, L-glutamate, alpha ketoglutarate plus NH4. Now this is mainly one thing that is important. Branch amino acid, and these amino acid by transamination reaction formation of ammonia is from glutamate, and this glutamate going to the steps formation of alanine, and these alanine going to the formation of glucose, means it is glucogenic amino acid, okay, by the process of gluconeogenesis and this other urea, formation of urea. And this is the overview of this catabolism of amino acid, that we take directly protein in our diet, and protein is what? It is a long chain of amino acid which contain polypeptides, okay. And these amino acid further going for transamination reaction formation of alpha keto acid, and which form directly pyruvate, okay. And these alpha ketoglutarate forming glutamate. Glutamate, you already know, it is a amine contained substrate which is further on release of urea by ammonia, disposal of ammonia, urea cycle. That means the liver is a major organ which can regulate the level of urea and ammonia. Understand? So if the liver is not functioning well, if the person having liver cirrhosis, if the person having fatty liver, if the person having viral hepatitis, then ultimately leads to high level of urea and ammonia in their blood. That's why physicians suggest to regularly check up of this ammonia in ALD patients, acute liver disease patient, okay. First step is transamination, second step is deamination, that is formation of ammonia. Third step is transport. Fourth step is reaction of urea cycle. So in all these steps there is disposal of ammonia. And this is the cycle. I already tell you that it is two steps, two main steps proceed in mitochondria and other steps proceed in cytoplasm. You will see the reaction, all of this arginosuccinate, arginase, urea, ornithine, all this proceed in cytosol. And this fumarate directly going to citric acid cycle. That's its TCA. I think all of you understand this. All of you understand? Breakfast nahi kiya? Speak loudly. All of you understand? Okay. These all are the disorder. Hyperammonemia first, hyperammonium second. Acha, I will ask question. CPS first is present in the mitochondria. Where this CPS second is present? Huh? Cytosol. Cytosol in the liver. गोल्जी बॉडी में नहीं होता, कुछ भी बोल दिया है, ऐसा नहीं है, सोच समझ के आंसर दो हमेशा. थिंक बिफोर यू स्पीक. अच्छा, if the person is suffer from high level of hyperuremia, how will you treat it? What will you suggest? क्या सजेस्ट करेंगे ऐसे पेशेंट को? लो इनटेक प्रोटीन डाइट, frequent small meal to avoid sudden increase of blood ammonia level. Okay, this is only a suggestions. In the next class, we all discuss about different amino acid metabolism in detail, and there is some also cases. इसमें cases भी होते हैं. Cases क्या होंगे वो देख लीजिए आप. Cases कैसे होते हैं? If a subject is directly admitted in the OPD in severe coma state, okay, and they having symptom of, एक नॉर्मल प्रोफाइल दे देंगे जिसमें आपका SGOT, SGPT बढ़ा हुआ होगा, SGOT and SGPT are increases, ammonia levels are increases, okay, and hyperammonia condition are there, and the symptoms are maybe tremors, blurred vision, slurred speech, okay, and last one is it finally leads to coma. So now you will diagnose a disease with defective mechanism. So how will you treat it? How will you diagnose it? If there is high level of ammonia, if there is high level of transamination reaction, then you leads the person is suffer from different kinds of CLD disease, that is acute liver disease. It might be a viral hepatitis, it might be a fatty liver disease. If the person is liver cirrhosis, then there is high level of urea in their blood. And from this, it can be detectable. Okay? Okay, thank you.
Good morning. So with this small this thing, gesture, I would say, actually now the most, every part is important, but abdomen is known as the Pandora's magic box. সেই পিসি সরকার একটা পায়রা দিচ্ছে, এখান থেকে একটা রুমাল দিচ্ছে, এখান থেকে একটা ফুল দিচ্ছে, এখানে এই করছে, তো সেই রকম মানে the Pandora's magic box, you are not knowing what is in your clinical practice exactly which organ is affected, how you have to deal with the abdominal pain or any acute condition in the abdomen. Now with this we'll just go and a bit of introduction, and today is the rectus sheath, but you have read thorax, ribs. Now the few muscles of the anterior abdominal wall and are originating from the thoracic skeleton. Now similarly, now when you are reading osteology, you are reading osteology in the abdomen, that is the hip bone, lower limbs to tar songe thakbe, vertebra to hoye geche up to thoracic. Now the lumbar, sacrum, hip. Now you have to say lower abdomen, upper abdomen, and the middle part. Now the one just overlaps each region. Now you will be doing that the division. Now the hypochondrium, epigastric, lumbar, umbilical, iliac, hypogastric. And see what I want to do, the lines dividing the part of the body. Now you have to be very specific. In say the right iliac fossa pain, which is commonly mostly is appendicitis. You go and when you read and you see the upper right hypochondriac pain with vomiting or some jaundice or presentation. Now that you think of cholecystitis. Now there's a like gallbladder point in surface marking you will be knowing, and that gallbladder point is tender, and at the catch of the breath, নিঃশ্বাস নিতে বললে পেশেন্টকে তখন you just take your palpating finger. Now this is the করবে, then it is Murphy's sign is positive. Now Professor Murphy, he was attacked with acute cholecystitis. Now what happened? He was palpating, sleeping in his hospital bed, and he pressed, and since that is known as Murphy's sign. He called the sister and said, please note, and he just gave the incidents, narrated the incidents. The sister copied and said, write Murphy's sign, positive. In the era of this thing, only radiology, but no USG there. Even I had the opportunity now. We used to diagnose it to some extent. And there's a word in abdominal operation, exploratory laparotomy. Explore. You're going to Antarctic, you're going to North Pole, you're going to the moon. It is like an exploration, opening the abdomen, and you see, you palpate the gallbladder, and then you pull out stones. My father was a champ in clinical diagnosis. I started assisting him from third year. Naturally, that time, most of the diagnosis was done clinically. So you can diagnose cholecystitis clinically, but, I say a big but now you have to confirm it with an ultrasound. And I tell you, USG, you don't go for a CT, MRI on the first prescription. You do a diagnosis, you'll be more than 90%, I'm 10%, I'm leaving it for other pathological conditions. But that will be reflected in the USG plate. There is a lump, there is an addition, there is stones in the CVD, or in the CVD. Naturally, there is jaundice. I told you just about a case presentation, and naturally there will be. Now you go for, if there is a CVD stone, then you go for if the mass is there, then you have to be confirmed that if it is malignancy or not. Then it goes into the your MRI CT and FNAC if possible. And if there is no mass or something, there is CVD stone, and when we gallbladder stone impacted in the neck, there will be multiple stones in the CVD. Now, what happens? You have to manage this case. Or now, what are the like CVD stones can be managed by endoscopy, by ERCP, removing the stones by the GI endoscope, and then removing the stones, and then the stone of the gallbladders can be on a CVD stone clear kore dile, then you go for cholecystectomy. It might be open cholecystectomy and also laparoscopic cholecystectomy. Now, with the modern thoughts, I'll go and see the organs of the abdomen. Muscles of the anterior abdominal wall. Now the muscles, the rectus abdominis, external oblique, transversus muscle, internal oblique, and now I just want to show you. Now see the origin of the muscles. The external oblique from the ribs, you have seen the ribs, you have knowing, just correlate that this muscle is coming from here and where it ends, where it gets inserted. It is like your clothes. one by one the layer is there. Imagine. And now I tuck, I'm not having my shirt out, I've tucked it inside the pant. Now this gets inserted in the iliac crest. That's a common question when you hold the hip bone, the iliac crest, you ask, you say this is the hip bone, this is the upper end ilium, symphysis pubis. Like this you go on describing. Now, any examiner will ask you, okay, tell me the muscle insertion on the from medial to lateral or lateral to medial, wherever it is you are comfortable. Then you go and narrating on the iliac crest, the portion, the attachment of these muscles. See, and also the hip bone is a here the pubic tubercle and superficial inguinal ring. Now this muscle, this is the iliac crest. Okay. Now again internal oblique muscles, see how it is attached. Here is this is the lumbar fossa. This is the rectus. Here is a beautiful picture, hand drawn, of Gray's anatomy. Beautiful illustration. See the muscles. This is the pectoralis major, this is the serratus, and you can see the latissimus dorsi, obliquus externus, and linea alba is here. And this is the muscles in the intersection and linea alba here. And this is liminal simultaneous. And this is the crest of the ilium, the inguinal ligament from the anterior superior iliac spine to the pubis. This portion. And this is the inguinal ring. And this is the lacunal ligament. Now, all this is visible beautifully if you just dissect or the body, dissected body, you can view everything, lacunar, it gets the conjoint tendon, the inguinal canal. And see, this is very important when you read the inguinal canal. And if you go for surgery, you have to know the anatomy very well. Because now you have to, there are around 15 to 16 types of operations. Now today, even in these days of laparoscopy, few people go for laparoscopic operation. And now there's numerous sutures and mesh, proline mesh, and mesh hernioplasty. That you will go, when you read surgery, you will be knowing. But where this mesh will be placed and fixed to actually inguinal canal is not a canal. It is a trough. And the tendon part is there. You have to just oppose. In previous days, we used to bassinis repair around 15 to 16 operations. But I had modified on the operation on inguinal when this mesh was not there. That is a suture of figure of 8 when you discuss with the hernias. So I have modified because seeing that, but the physics behind is that figure of 8, the tension, like you cough and this thing. Previously we had catgut. Naturally we used to do bassinis repair mostly. My father and our teachers, they used to do bassinis repair. And now what I want to stress is you see the abdominal muscles. You see your Ronaldo, then his rectus, Bruce Lee, the great martial art champ. Now see inguino-aponeurotic flex, this part, the cremaster muscles and the pubis here, and this is the muscles, the obliquus internus. and this is sheath of the rectus. Now you see the muscles here again. See, this is the linea alba, and this is the rectus abdominis muscle, and sheath of the rectus. And you can see this tendinous interruption. মানে একটা strap muscle total from this part going up to the pubic tubercle. Naturally, এগুলো part এরকম করে থাকবে যারা মাসল আমার তো ভুঁড়ি হয়ে গেছে বিশাল হ্যাঁ কোনোদিনই আমি ইয়ে বাট আই হ্যাড আ গুড দিস থিং এখন ভুঁড়ি টুড়ি হয়ে অনেক কিছু হয়েছে সুখ ভুঁড়ি হ্যাঁ স্পেশালি আই এম ইন্টারাক্টিং উইথ ইউ এই দুদিন আমার খুব ভালো লাগে জায়গাটা আর তো এইটা দেখাচ্ছি তোমাকে যে যাদের তোমাদের বন্ধুদের মধ্যে বডি খুলে দিল তার পুরো রেক্টাস অ্যাবডোমিনাসটা দেখে নাও হ্যাঁ অ্যান্ড এই যে ভাঁজ করা আছে এগুলো কিন্তু একটা কম্পার্টমেন্ট দেখিয়ে দিচ্ছি যে টেন্ডেনিয়াস কম্পার্টমেন্টস আর দেয়ার আমি ইঙ্গুইনাল লিগামেন্ট এখন বলছি না দিস ইজ দি হিপ বোন see the illustration from Graves, no one can outsmart these drawings. And you see your vision, your concept will be clear. See ligament of Cooper, you see the thing pubis, symphysis pubis, obturator membrane. See the structure of obturator membrane. এই ইন্টিগ্রেশনটা তোমরা করবে যে অ্যাটলাসটা নিলে বইয়ের ফিগারটা নিলে একজন তোমাদের টেক্সটটা পড়লে যে দেখবে যে এই ছবিগুলো তুমি কোরিলেট করে নিলে যেমন obturator foramen when we ask what is the structure that is attached just blank point blank থাকে সবাই বলবো না I'm sorry sorry হ্যাঁ তো এটা নেক্সট কর নেক্সট তাড়াতাড়ি নেক্সট এটা জাস্ট নেক্সট স্লাইডে চলে যা নেক্সট 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 but now you see the rectus abdominal muscle that is opened okay next anterior wall next posterior wall medial margin lateral margin content now this is important এটা থাক now this is important now you see the rectus muscle is between this is the linea alba is in the middle and that is the tendinous intersections like this and actually previously or even whatever the type of operation it was a huge mass then you big incision you have to make and the right paramedian incision median incision left paramedian accordingly and now you see the rectus muscle here linea alba extraperitoneal fat this is the peritoneum and this is the fascia transversalis and see external oblique internal oblique and transversus these muscles come and they are covered by the tendinous sheath. Now see the superficial fascia, pectoris major muscle, the rectus muscle is here. This is the xiphoid process. See the level. এই লেভেল থেকে তো তোমার এখানে আসছে this whole rectus sheath. Now you see these diagram, every book you are having, so you please get your knowledge today only if you want to read it. Now you see similar external oblique, internal oblique transversus, fascia transversus, peritoneum. Now what I want to see is that a long question or a 10 marks question, rectus. Rectus sheath, very depictive, picture is depictive. Superior epigastric artery, the xiphoid process, and you see the lineama, this is the umbilicus, and you see the lateral margin of the sheath. Now, you see the lateral margin of the rectus sheath, the intercostal arteries, the deep circumflex iliac artery, position of the deep ring, inferior epigastric artery, this is going there, and superior epigastric artery, the contents of the thing, the rectus sheath, and see the nerve, the T7, T8, T9, T10, T11, T12, and number 1, hypogastric nerve, ilioinguinal nerve. Now, that's why the ramification of the nerves are there. Sometimes people complain in after surgery, ডাক্তার এখান থেকে এরকম যেন অসাড় হয়ে আছে, কিছু বুঝতে পারছি না। তো আমি বলো দেখো ওগুলো তো কিছু নার্ভ কাটা গেছে, ওগুলো ঠিক হয়ে যাবে, ঠিক হয়ে যাবে। By time the person starts ignoring.